Can anyone hear me here? Yeah? Oh. We're supposed to start 5 minutes from now, but as long as we're here, let's start 5 minutes early. Yeah? Is that permitted? Yeah. So while we're setting up, may I ask the audience some simple questions? Who here, on a regular basis, next Monday when you're back in the ICU, does lung ultrasound on every patient who's on a ventilator every day of the week? And if there's any change in respiratory status, they do it 10 times in a day. Is there anyone who's really fanatic about lung ultrasound? You are. Every patient. But as indicated, I'm joking. Anyone else is deep into lung ultrasound? Meaning a few of you are, but you won't want to admit. Yes? Yes? Where are you from? Qatar. Yeah, nice. Okay, yep. All right. And how about who in this room has some familiarity with lung ultrasonography? Nice. So you know what A's and B's are and C's and D's, but you don't know what a Z line is yet, right? Okay. All right. And who here is entirely innocent of lung ultrasound? You're just here because you're almost in the wrong session, or you just want to learn about it. Are there any totally innocent victims in the audience? Oh, all right, good, good. We have a visitor from Brazil. His name is Nick Alice, also known as Nick Golinski. That's right, which I'm going to guess is possibly of Polish origin. Yeah, am I right? But your family has been there for a while. Yeah. So I would advise taking off your jacket because you've decided to be hard at work. And the first issue here is roll up the sleeves because you don't want gel on them, right? And do we have a model? Is it possible here? Ah, we have a model. I'm glad you're not very large. Okay, good. Would you care to sit down? Yeah. All right. And what I would advise, if it's not too cold. Yeah, okay, good. All right. And your comfort is our concern. So lie down, and I'm going to give you a pillow for your head. Okay? Even though you're young, your neck, it'll be uncomfortable, okay? So, oh, all right. Okay, good. So, Nick, do you want to sit down when you're scanning? The comfortable scanner is the better scanner, right? At work, you may be running around. Nick works, he's still in training, does a lot of ultrasound in his very busy ICU, correct? Yep, all right. And the only thing is, it's a problem with a small chair with a big guy, so you'd ordinarily be a little higher, right? If you want to stand up, don't worry. So the first step is to understand how to apply gel. Cardiologists apply little bits of gel, but a guy like Big Nick, who's critical care, he doesn't fool around. And the reason for that is you want to be able to grab it and go instead of going back to get it, correct? Yeah. All right. So are we allowed to start now? 15. In 45 seconds, we'll start the official presentation. And I was told that one screen would light up with a PowerPoint presentation, correct? And I'm always worried that we may have a parallax view here. Like, are you going to be able to see the ultrasound machine? I doubt it. So if there's any way you can move laboriously in this direction, and the best positioned person in the room is you, because you can see here and here. So gather together, cheek and jowl, right? Okay. So in your ICU, you have 3 choices for imaging. You have something called chest x-ray. Huh? You have something called CT, that's serious business, not exactly portable. And every time you do a CT scan, please ask your patient, is it all right if I do 400 to 800 x-rays on you without your permission, even though most of the time the CT is unnecessary because I could have done lung ultrasound? Oh, please do that, all right? So CT, obvious as application, but lung ultrasound, this is the challenge that you face. non-specific aeration pattern. Summation artifact. Next slide, please. How do we do it ourselves? We have a clicker? Yeah, where's that clicker going? Ah, I see it. All right. You know what's wrong with those x-rays. They're supine, rotated, under-penetrated, over-penetrated, and worse, they represent a three-dimensional image structure in 2 dimensions. They squish the entire thorax down to 2 dimensions, so you're subject to summation artifact. There's opacity. I don't know if it's outside of the chest, in the lung, or in the pleura. I don't know. Better do a CAT scan, or better still, do lung ultrasonography. Then you have problems with variability of the test, how it's interpreted, confirmation bias, but especially in my ICU, I order a super stat chest film. It takes a couple hours to get it sometimes, and the patient's already dead if they have a tension pneumothorax, right? So it's very irritating, the delay. And in addition, it has to be interpreted by this person called a radiologist who doesn't know anything about the patient, right? So anyway, you can tell I don't much like chest films. In fact, in my 30-bed operation, we don't do many chest films. I'm talking about practically none, because we do a lot of lung ultrasound, and lung ultrasound is not perfect. No. It's not for the respirologist who's looking for a little pulmonary nodule or a mediastinal abnormality. No, that's not for. But for the stuff, the bread and butter that we're looking for in the critically ill patient, pneumothorax, normal pattern of aeration, interstitial consolidation, pleural effusion, it kills chest films. And it rather mimics, according to convincing literature, CAT scan results. So suddenly, if you're really good at lung ultrasound, you're carrying a portable CAT scanner in your hands. That's interesting. It's essential skill, therefore, as is general body ultrasound, also known as WUBU, whole body ultrasound. These are essential skills, I think, for any serious critical care person. Just my opinion. So, why are x-rays still used? You know, because, hey, let's order it. It's my habit to do it. It's really easy. You hit a button, and therefore x-rays are not for clinical activists. They're for armchair intensivists who sort of sit back and let's round outside the patient's room. I look at an ICU team, if they're not at the bedside, touching the patient, smelling them, listening to them, scanning them, that's not, I don't think, a serious team, all right? So you have to be really committed to really getting up and close and personal with your patient, which is where I think we all belong. So with that brief introduction, you use it for initial evaluation of presentation of respiratory failure on rapid response team runs, in down in the ED, sudden deterioration, very useful, but also for tracking evolution of disease. And you can characterize ARDS as geographic or regional. You can follow up and diagnose ventilator-associated pneumonia. You can make extubation decisions in difficult cases based on lung ultrasound. All of this, of course, is always combined with echo and all that other stuff. So, how to do it? Nick, show us a phased array probe. Yeah. So, you can use either a cardiac probe with appropriate preset, or you can use a big curvilinear. It's up to you, but they both work. And Nick, how are you actually going to do this? Could you show us the proper handhold and the insonation angle? What do? He drops the probe on the patient's chest, and he aligns the tomographic plane longitudinal, and he's very careful to maintain a perpendicular angle. And then once he does that, he's going to select the best machine setting by gaining and setting depth, etc. I think that now you look good here, but this overgains. Let's turn down the gain. So this often happens. Oh, look. And then he moves a little bit. Show us a rib shadow. Yeah, we don't like rib. We hate ribs. So he moves off of the rib, comes down, and then he examines an interspace. That's how easy it is. The problem is there are a lot of interspaces, right? So depth I accept. Gain, now that we've adjusted, is acceptable. And what can we then do in terms of like moving the probe around, because the lung is the second largest organ in the body. The skin is the first, okay? So notice what he's going to do. He's then going to slide his probe to the next interspace. Stops there for a second, goes to the next one, so he's satisfied with that. And then let's go over here a little bit here. He's doing a quick scan, developing in his mind's eye a mental image of the lung. Okay, by doing multiple scan lines, slides down there, a little further, one more, and then, and then he runs into the liver. This is not an anatomic discussion, okay? Then he's going to do mid-axillary line. You see how you progress looking at multiple interspaces. He slides down, and he's looking at each one, not hitting a button to freeze it. This is a dynamic scanning pattern, okay? Come down one more after that, and one more, and there's run into the liver. That's all right. Everything looks pretty normal. We'll talk about that in a moment. Then he comes the more difficult area. Evil lurks in the posterior lung of the patient who is supine. That's our patient, right? So he's there. Oh, whoa, you're going to have some fun there. Okay, yeah, all right, we'll get back to those things there, okay? Scan on down, downtown, further, down, this way, and show us the liver there for a second. Oh, that's interesting. Show us the diaphragm. We're not supposed to talk about that. He's so well aerated, you made out to see it there too well. He's going to use unsedation window to get up here. Yeah, all right. There, all right. Oh, that's moving normally. Sorry, we're not supposed to talk about that today, just lung ultrasound. Now, the problem that you face is you cannot see the posterior chest very well, so then you gotta take action. Works, yeah? Then you get the intern to hold the endotracheal tube, don't worry. Yeah, okay, yeah. And then the intern, and then you got another team member, all right, haul him over like this, watch the endotracheal tube, scan his back real fast. Here, get some of this gel over there, okay? Okay? So come, whoa, and look. Now he's going to really take a careful look at where evil lurks, right? Scan up, down, a couple interspaces there, and there is an area that's invisible behind the scapula. Nothing's perfect. So that's how you do it. Let's lie back for a moment, okay? You do it the other side too. So the question is, what are you looking at? Some of you know. It's child's play. We'll do that. We'll come back to that in a moment. Yeah. Let's have the next slide if we could. Yeah. So there it is. Line approach. Some of our European colleagues, the super academicians, use a zone approach. Zone 1, 2, 3, 4, 5, 6, and they score it to derive the lung ultrasound aeration score. Yep. Over in the U.S., we do lines usually, but if we're going to do a research project, we do aeration score. That's good. Next slide, please. I'll do that myself. And let's then talk about the basic, simple findings of lung ultrasound. You're out on an RRT run, acute dyspnea, and the resident says, yeah, I just put in a subclavian line and it was a little bit difficult. Patient's going at it. What's the first thing you think about? Do they drop a lung? Does this guy have a pneumothorax? Let's see. Yeah. So, comes over there, looking at this. Oh, yeah, down gain a little bit because we're bright. And what I see over here is lung sliding. What I'm seeing is the interface between the visceral and parietal pleura when the lung is fully expanded. As the lung moves, you see movement of the pleural line. The pleural line is right here. There's no pneumothorax. Someone says, well, maybe they have a little one next door. Hey, how about scanning a couple of interspaces very quickly? One, instantaneous rule out of pneumothorax. And if you see lung sliding over the anterior chest in this situation, it's like birth, death, and taxes. That's what he said. It's absolute. Do the other side because there are always two lungs. So that's the basic initial look-see. Do they have a pneumothorax with acute respiratory distress? It took him about 30 seconds because he was going slow. All right? Now, an interesting feature is if the patient suspends respiration, put it over here. Look, this is a subtle finding. Beat, 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 beat. Downgain that a little bit. Beat, 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 beat. That's called lung pulse. Breathe again. Breathe again. Okay, yeah, okay. And lung pulse is just cardiophasic movement of the lung that's fully inflated. It has the same meaning as lung sliding. You see lung pulse? They don't have a pneumothorax. Oh, but wait a minute. Some eager house officer has shoved the endotracheal tube into the right main stem, and they've inflated the balloon to block the left. You're bagging. You see lung sliding over here, but none over here, just lung pulse. Ease that endotracheal tube back until you see bilateral, an interesting application. So, next finding, let's go, is something called lung sliding that is absent. So you already know if you have lung sliding, you don't have a pneumothorax, but if you lack lung sliding, does that mean you have a pneumothorax? And the lack of lung sliding is like marriage. He said an uncertain proposition. Under my ring it says DNR. Do not remove. I got you. All right? All right, good. So the absence of lung sliding, you have to be a little bit careful. For example, the apneic patient won't have it. The dead patient won't have it. The patient who has pleurodesis won't have it. The giant bulla will cause absence of lung sliding. Proceed cautiously. Clinical correlation required. And maybe even, God forbid, a chest film. Okay? So the presence is 100%. Absence, clinical correlation required, but it is obviously associated with pneumothorax. And if you're lucky, you see something called a lung point. And a lung point is more advanced. Imagine this. If our subject was given a pneumothorax, you got that needle? No. He drops down, and the lung is partially deflated. So you have pneumothorax up here, inflated lung down here, unless it's 100%, which is rare. And then if you carefully, cunningly slide the probe, and you find the exact interface, the point between the partially deflated lung and the empty space, you get a lung point. Here, I see the lung moving in and out of an empty space. That's diagnostic of a pneumothorax, but it's hard to find, especially if you're not experienced. Once you know how to find them, you find them quite regularly. Correct, Nick? Yeah, it's very interesting finding. All right, so let's go with our next one. Oh, here's a little representation up there where you have the partially deflated lung, no pointer here, where the probe is placed exactly at the point of interface, and you can see the inflated lung coming in and out of the empty pneumothorax space. A-lines are the next classic finding.
lung sliding, lung pulse, when you're advanced lung point. A-lines, show us a couple of A-lines. So notice that he drops onto the chest wall. He locates the interspace, change depth to go a little bit deeper, and he sees multiple horizontal curvilinear lines that are called A-lines. I don't know why they're called the A-lines. EKG, a QRS. Does anybody know why it's called a QRS? Lost in time. The justification for that. But here, these are called A-lines, probably for air. And A-lines with lung sliding indicate normal aeration pattern at the site of that examination with a high level of probability correlated with CT scan. All right? So, of course, there are a lot of interspaces to look. So he might have normal aeration in something next door. So guess what Nick does? He just slides down. A. So this line is normal aeration. Over here, you saw them all there. Just tons of A-lines, which we'd expect in a young fellow like this. And that's incredibly valuable because if you have a person who's acutely dyspneic and they have A's all over with lung sliding, it means they have a normal CT scan aeration pattern, normal X-ray, delayed many hours. So you're thinking, why is their lactate 4? That's why they're breathing with difficulty. They have airway disease, COPD, pulmonary emboli. All these things cause normal aeration pattern with respiratory failure. So it guides you towards that differential. Okay? So A-lines, everyone in this room is A-line predominant. Yeah, I'm pretty sure. Okay? I'm looking for findings of respiratory distress, which I don't see. All right, good. So A-lines, easy to find, very common to find. And if there are A-lines, there must be B-lines. Exactly, Nick. Okay, yeah? All right, so let's go. B-lines are totally different than A-lines. They're vertical in orientation. They start at the pleural surface. They move with the pleural surface. They flare out. They're hyperechoic. They reach the bottom of the screen. Pretty good examples here. What do they mean? All that it means, if you did a CAT scan or an X-ray, you would see a interstitial abnormality. Is that a diagnosis, Nick? No, that's a finding, and it's up to you to find out why they have a finding like that. And A-lines can be in one little spot. Everything else, no. They can be segmental. They can be whole lung. They can be bilateral. You lived the COVID life, right? So did I. We saw B-lines all over the place with COVID, right? So it's only a finding. You're the clinician, just like if you see something on chest film or CT. That's not a diagnosis. You have to use your brain here, okay? So we were fortunate enough to find a B-line here. Nick's an expert level scanner, so he was like, Hawkeye, show us that B-line you found over there. And what you need to know is that every one of you have one or two B-lines lateral. That's normal. Don't worry about it. Okay? It's all about distribution, number, et cetera, et cetera. Be ready to freeze that. Oh, those are more like parasite lines. You had a really good B. Look around. The other place you might find it at the middle fissure. Okay, sometimes you can pick one up there. Yeah, but you there. Yeah. Whoa! Look at that. Probably he's on a fissure line there. That's where the right middle lobe fissure is. That B line. That's a good example of one. What does it mean? Here, nothing. Just a fissure line, right? Okay, good. All right. So, B lines then occur focal, multifocal, bilateral, just like findings of interstitial abnormality on chest film or CT. Next is consolidation. So we've done lung sliding / pulse, lung point, A lines, B lines, and now we come to consolidation. And they come in different sizes, just like on other scannings. It's either little tiny consolidations. Here's one over here on the left, or non-translobar, meaning segmental consolidations, or consolidation that involve the entire lung. So what do they look like? All right. When lung is consolidated, it becomes tissue density. Show us his liver. And if you see something that looks like liver above the diaphragm, that's consolidation. That's the liver. Look at this size of his IBC. He drank a lot at lunch, right? Look at his diaphragm over there. He's moving north. Hey, give us a sniff there. Just sniff. Oh, yeah, he just did a sniff test. Yeah, his diaphragm's working. Yeah? Okay? So if you see that now slide above the diaphragm, and he finds normal aeration, higher single beadlet, go a little higher, 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 and compare that image to these images over here. That's tissue density lung. By definition, it is consolidation. The one on the right is consolidation because the patient has a large pleural effusion that's compressed the air out of the lung, so-called compressive atelectasis. Here we have, is there someone from the Netherlands here? I hope so. Are you with the Amsterdam group? Okay, because the Amsterdam group is now the big shots of the lung ultrasound world, okay? Great recent article where they said if you have translobar consolidation or non-translobar with mobile air bronchograms, you see them, it's subtle, but you see those movement, the movement of the air trapped in the bronchi, it's moving independent of the lung. That means with almost an absolute level of probability, they have a bacterial pneumonia. Suddenly it's a diagnostic tool. Lichtenstein first described that 20 years ago. The Dutch, your colleagues, validated that. So an interesting finding. All right. Then pleural effusion is a slam dunk. You can see them just as well with CAT scan. You can see internal echogenicity patterns, et cetera, et cetera. So this is a basic application of lung ultrasound. You find the effusion, you decide, can you get a needle into it safely? And then you characterize the internal echogenicity. And you get all types. For example, the one on the right is anechoic, but I notice deeper there's some sedimentation effect, so there's some complexity there. Of course, we'll tap that to see about that. The one over on the left, it's a small effusion. We're not going to tap this one with, guess what? A segmental consolidation pattern. I'm looking at a CAT scan. By the way, I can see the heart beating because that's an ultrasound window that allows us to see the heart, okay? And sometimes you run into some problems when you do pleural ultrasonography. I see on the right side the dreaded black widow spiders pattern of the loculated, neglected empyema cavity. Something's has to be done about that. And I see over here homogeneously echogenic, but those who know a bit about ultrasound, we see the descending aorta with a dissection in it that is perforated into the adjacent pleural compartment with the typical echogenicity of fresh blood. That patient was very, very ill. Saved by immediate ultrasonography. No CT or X-ray was necessary here. The surgeons took the patient to the OR on that basis alone, right? Happily. More advanced, our Dutch colleagues are telling us we can distinguish between ARDS and CHF with lung ultrasound by looking at pleural morphology. Every one of you, including our youngster here, has smooth pleural line. Hey, light up that vascular probe. Now we're going to get up close and personal. Vascular probes give great resolution. They lack penetration. And they're really good to look for the smoothness of the pleural surface. A normal pleural surface, all of you have smooth pleural interface. This image shows fragmented, thickened, irregular pleural interface. Yeah. Look how thin it is. No irregular, no fragmentation. The sophisticated European scanner goes to a long axis view. Yep, there. Smooth, smooth. If there were B-lines with smooth pleural surface, you better get out the diuretics. They're all over the place. That patient has elevation of LAP. Treat them for CHF. If it's irregular with B-lines, it's primary lung injury, like ARDS, or bilateral, horrible lung injury pattern. But remember well, all of those patients may also hide CHF behind their ARDS, and therefore you deploy echo in that population to estimate LAP. We'll finish, actually, on time. Without a summary slide. I'm glad to hear that.
Because in the remaining, I think we finish at at 3:35, I think, yeah? In the remaining 4 minutes, it was a brief review, primarily to reassure the experts in the group that you're doing the right thing, and to convince those folks who have started to do it more, and finally those who don't know too much about it, take it up next Monday. You have any questions here from the group? No, all right. And we're hanging around for a bit outside. Yes, go ahead, loud and clear. Wait a minute. Yeah, look what I have for you. Okay, maybe hand that back. That's right. So what's your question?
Yes, my question was, you said you can take whichever probe you want.
Yeah.
Like the cardiac probe or
the curvilinear.
The curvilinear. But is there any situation when you say you might want to choose this probe, and if you have the suspicion that it is this?
Where are you from?
Sweden.
So up there in Sweden, you guys got a lot of money, I hear. You got a lot of machines.
No.
Us poor folk in New York City, listen to this. Our machines have a linear probe and a phased array, and they won't give us curvilinear.
Okay.
Because there's some sort of tariff on them or something. Mm-hmm. That's a joke. Okay, yeah. So we just don't have the curvilinear. In Europe, curvilinear is used quite often by the experts. Where the real question is, because the results are similar, they really are if you know how to hold the probe. Where the real distinction is between when do you use the linear high resolution versus the probe's curvilinear phase that penetrate deeply. And there you do that if you're very concerned about pleural morphology, or if you're in a big argument at the bedside, do they have lung sliding or not? In a critically ill patient, and you bring out the linear probe because you see it much more clearly. See what I'm saying? Yeah. You have an ultrasound up there in Sweden? Good. I bet you have 3 probes.
Yes.
Yeah, because you're not in New York. I guessed right. Okay, good. Yeah, any other questions here? Oh, yes. Oh, yeah. Yeah. Oh, the other thing to mention is that we're getting into using, we have all the good machines in the ICUs, but when we're running around on the floor, you can't haul a machine this size upstairs. So you're running it without your weapon of war. So we're now using in the city more and more for rapid assessment at point of care, the UPUMs, ultra portable ultrasound machines. You got one handy here to show? Yeah. Where is it? Oh, yeah. So what you can now do is, what we do is we mount a holder here, so you can sort of hold it. I have a friend who actually mounts it on his arm, like a robo-doc or something. It's a little crazy. And this fits pretty, you can use it with your phone too, right? Yeah. You put it on your phone, and this fits into your pocket. So all of a sudden, you can do anything, anytime with any of these devices. This is Lumify, which has a very nice probe. We won't project it, but keep this in mind. They're going to be coming out, and I am a neutral observer of the industry. I'm not here to push any product, but this is a very, very capable machine for quick cardiac, for quick lung, quick abdominal, vascular access. Okay? Yeah. So keep that in mind as an important option if you're well equipped with big machines. Okay? Yeah. All right. All right. That's it? All right. That's it. Yeah. All right. Thanks for your attention. I hope I've stimulated your interest. Okay. Good.